Thank you very much for having me, and it's a real pleasure to be here. I've never been to Saudi Arabia before, so I'm very grateful for the opportunity to come and see the country. I'll be talking about multiple myeloma and CAR T cells. As mentioned, I focus on myeloma clinically, so I'm happy to talk about anything about myeloma, but I really have a specific interest in CAR T cell and immunotherapy. These are my disclosures. So we're going to be talking about BCMA CAR T cell therapy and talk about BCMA as a target. We'll talk about some of the data that's current, but what are the limitations of what we have so far. Talk about future directions and how we're going to make this more available to people. As all of you know, the CAR T cells combine the best of both worlds, which is the extracellular specificity against an antigen, so similar to an antibody, but the intracellular cytotoxicity of a T cell. So that gives us a way to get to specific tumor antigens and tumor cells, but still have cytotoxicity to kill those cells. So if we're looking for tumor antigens in the setting of myeloma, as we know for lymphoma and for ALL, CD19 is a target, but BCMA has actually turned out to be a very nice target for multiple myeloma. It's a member of the TNF receptor family, and it's expressed on myeloma cells, plasma cells, and early B cells. It regulates actually B cell proliferation, survival, and maturation to plasma cells, and its expression may be associated with myeloma burden and survival. The most important thing of it is that it's exclusively expressed on plasmablasts and differentiated plasma cells, which makes it an ideal target in order to be targeted for myeloma because it's not expressed on other hematopoietic cells or stem cells. So this allows for specific targeting of the myeloma cell itself. So, as you can see here, this is pictured in this diagram that if you look for BCMA, you can see that it's very, very nicely expressed on plasmacytoma cells, but not on any of the other organ cells in the rest of the body, which again makes it a very good target. So the first data regarding BCMA targeting T cells was actually presented as a late breaker abstract back in 2015, I believe, by Jim Kogedover's group at the NCI. And here they gave a retrovirus-based CD28 co-stemmed BCMA T cell to patients with relapsed refractory myeloma. As you can see here, they did have some dramatic responses, particularly in their higher patient dosing cohorts, but this was also complicated by a lot of CRS. They were actually able to update their data recently in JCO, and they were able to show an overall response rate of 81% with an EFS of 31 weeks. So this was sort of the first T cell product that we had. Soon after followed a PEN product, which I won't go into. But I do want to go into what has been one of the most popular BCMA trials that has been quoted a lot, which is the BB2121 BCMA CAR T cell. Now this is a CAR T cell, similarly, as we discussed, that targets BCMA, but it's with a lentiviral vector, and it has a 4-1BB co-stimulatory molecule. And in this study, this was published in the New England Journal almost a year ago. This was the phase 1 study looking at 33 patients who had had a median set of prior lines. So if you think about that, that's a lot of prior lines of therapy for myeloma. They were very heavily pretreated, and what they were able to show is that at the more effective doses, so higher or equal to 150 million T cells flat dose, they were able to get a response rate of 90% and a VGPR of at least 80%. When you look at the survival data, the reason I'm showing is this is the first real larger trial to show any good or any long-term survival data, if you can consider this to be long-term. But you can see here that the median PFS on the left-hand side for the effective cell doses was 11.8 months. This was better when you looked on the right-hand side at people that had achieved MRD negativity by at least 10 to the minus 5. Those patients had a median PFS of 17.7 months, suggesting that the depth of response does matter. But it wasn't necessarily a cure yet. I just want to point out that a lot of people look at this data and they may say, oh, but there's no cure, but you also want to remember that if you've had 7 prior lines of therapy for myeloma, it's really difficult to get any response at all. So getting 80% response rate is really something revolutionary in this very heavily pretreated patient population. So the KarMMa-1 study was the phase 2 of this. This is actually the press release, and this is going to hopefully be presented at ASCO and hopefully published soon. This is a much larger trial, almost over 100 patients. And I just want to point out that in their tops dose cohort, which is 450 million, which is going to be the recommended dose going forward to the FDA, they were able to have a response rate, again, of 81%, which actually is very similar to what they were able to get in the phase 1. And their median PFS here was 11.3 months. Again, very similar to what was shown in the phase 1. Median duration of response, also 11.3 months. So I think we can safely say that in this patient population of heavily pre-treated patients for myeloma, we're getting about a year's worth of response for those who do respond from the CAR T cells. That's not the end of the story, but I think it's a really good beginning. So there have been a couple of other products on the market. I just want to focus on the Legend product. This was a product that was developed in China against CAR T cells as well. This is again a BCMA CAR T cell, dosed a little bit differently, and this was presented several years ago at ASCO, made a big splash, initially showing 100% response rate. Ultimately, this data was drawn out for longer. We have longer follow-up now, and you can see here that the overall response rate was 88%, and they did some long-term follow-up. The Legend 2 study is an American version of it, but they've done some long-term follow-up from this LCAR. The Legend 2 study is actually being recapitulated in the United States as a CARTITUDE study. I'm going to go over that real quickly. But before I do that, I just want to show that the data that was seen from longer-term follow-up from this Chinese study showed that there was a median duration of response of 27 months. And patients that achieved a CR, actually those patients had a median duration of response of 29 months. Now, if you think about it, this seems a lot better than what I just showed you from the BB2121 data, but I also want to point out that the median lines of prior therapy for this population in China was 3 versus 7, which is what was true in the American population. And I think that's really important because we know, as myeloma physicians, that as the further and further you get out, it's harder to get a response rate, and those responses last for less time. So I'm very encouraged by this data to see that there was some good long-term follow-up, but I really do want to see what's going to happen when this trial is repeated in America with a lot of extra, and actually Europe, with a lot of additional treatment lines. And actually, very preliminarily, the CARTITUDE data was actually shown here. This is the CARTITUDE 1 study. This is the same exact product, BCMA CAR T cells, the same product that was seen in Legend, but actually now the trial was done in the United States. And the first group of patients here, the first 20 or so patients were presented at ASH this year. And as you can see by this plot, there was a 100% overall response rate. So again, very early, I think what we can say here is that the CAR T cells are very effective at initially killing a lot of the myeloma, but what is it about how long they can last? Can they be like ZUMA-1 and have a tail on the curve? We don't know that, and we haven't seen that yet. But certainly, at least now, I feel happy that this trial that is being recapitulated or repeated in the US and European populations, which have a lot more lines of therapy, actually looks like it's getting a little bit of a similar data that the Chinese got. And I think ultimately the proof will be in the duration of response. So this is just a table. I don't want you to digest every part of the table. I just want to point out that there are many groups looking at how to twist and turn this CAR T story. And I'm going to talk a little bit about some of those mechanisms. All of them show a response rate somewhere between 80%, usually 80 to 100%. But really what we don't know yet is the PFS. We only have some long-term follow-up from these 2 studies that I just talked about. And when we say long-term, we mean a couple of years. So that's really not that long when you consider how long a myeloma treatment, a patient goes through a treatment. So there are ways that we can go through this. And I think that, like I was saying, unlike ZUMA-1, where we really want to get the plateau, we don't have that. What we have here is on the left. We want what's on the right. And how are we going to get there? How are we truly going to kill myeloma cells? How are we truly going to maintain responses? How are we truly going to potentially cure patients with this exciting technology? So there's a couple of ways we can think about how we can make CAR T therapy better. You can think of, kind of break it down into categories, things like choosing the right target. Maybe we're not choosing the right target at BCMA. Maybe the cells themselves, how the T cells are made, how many memory T cells, product composition, that could be an issue. Maybe we can engineer these cells to be different, or maybe we're not using them at the right time. And so maybe we actually might be able to think inside the box, which I'll talk about later in the talk. So let's talk about target. maybe BCMA is a great target, but perhaps it's not actually getting at the root of the myeloma cell. So there's been a lot of search for different targets. So my colleague Eric Smith, who's at Memorial Sloan Kettering, has been looking for new targets, and he came upon this target called GPRC5. You wouldn't even know that it is a myeloma target, except for he screened many, many cells and targets to find this. And this protein is specifically expressed on plasma cells as well as hair follicles, actually very interestingly, suggesting that it might be an immune-privileged target. And he was able to show in mice that are BCMA resistant, as you can see on the right, that targeting GPRC5D actually did eradicate myeloma. And in addition, when he looked at dual CAR T, and he was actually able to make a CAR T cell against both GPRC5 and BCMA, there was much greater eradication of myeloma as seen in the top orange line. So this suggests that maybe if we're looking at targets, we might want to look at not just BCMA, but maybe BCMA and something else. And that's sort of a similar situation to what we've thought about with CD19 and 22 for the lymphoid malignancies. What about CAR T therapy product composition? So the group at University of Pennsylvania has done a very elegant job at trying to understand what happens, what you put into the patient, does it affect what you get out of the patient? And what they've been able to show is that the composition of the product, not necessarily actually the apheresis product, but the patient's actual own composition, the kind of lymphocytes the patient has going into CAR T cell collection actually can make a difference for what their outcomes are. The data is very early, but it suggests that how we make T cells and what the T cell quality is actually may make a difference. And because of that, other companies are looking at this. So this is the BB21217 protocol. This is the same vector as BB2121, which we talked about for the New England Journal paper. But what they've done here is they're culturing the cells in the presence of a PI3 kinase inhibitor. And this PI3 kinase inhibitor actually uncouples the cell differentiation from the proliferation. So at the end, the product that you get has more T central memory-like T cells in order to prolong and persist. The idea here is if you have more central memory or stem-like memory cells, those cells may persist in the recipient longer, and they may be able to then be tipped off again to actually treat myeloma if it should grow again. So this is a phase 1 trial looking at this particular type of cell culture with this PI3 kinase inhibitor. This was initially presented 2 ASH meetings ago and then updated this past year. As you can see, there is some follow-up suggesting that a group of patients are having longer duration. Follow-up is very short. What I think is more interesting is they were able to show on the left-hand side, if you have more persistence of T cells, those people tend to respond and respond longer. Not surprising. I think that's a theme that we've seen in many CAR T cell studies. But what was really interesting is they looked at the phenotype. Those patients that had phenotypic cells in vivo, those cells that actually had more memory-like phenotype, those patients were more likely to respond and more likely to have persistence by vector copy number. So this suggests that what you put into the patient actually does make a difference. And if we could be smarter about culturing cells to make them more persistent, more stem cell-like memory or central memory-like T cells, then maybe perhaps we could actually get a more effective product. Another company looking at central memory and stem-like memory T cells is Poseida. This is a different CAR T cell. Now, instead of using a vector, retrovirus, instead of using a viral vector, for example, a retrovirus or lentivirus, they use a piggyback system, which is basically a DNA transposon system. So they're able to get actually a much more refined payload of their genetic material into their cell, and they have a very interesting extracellular domain, which they call a cartirin or cartirin. And what that does is it actually is very specific for BCMA, but with very small peptides, or a very small number of peptides, and that makes it less immunogenic. And with this system, they're able to culture a product that's more enriched in stem-like memory T cells, and also get a phenotype that's much more pure. They also have a suicide gene incorporated, but have not had to use this. And the idea here, similar to the bluebird concept, is if they give a product that has more memory-like phenotype, they'll be able to have those cells persist for longer. They've only been able to thus far show some very, very early phase 1 data. As you can see, there's been some nice responses. But again, for a product like this, it's not so much how many people respond, it's what the duration of response is. And so we're looking forward to longer follow-up from this data as well. So what about cell engineering? This is, I think, one of the most innovative parts of what we've been talking about a lot this morning, really, how things have been changing to really take advantage of cell machinery, and what innovative ways we can look at this. So Cole Roybal, who used to work with Wendell Lim at UCSF, he's a very talented young man, I shouldn't say young, he's on faculty now, a very talented investigator, and he and his mentor developed this SYN notch system. So let me take you through this. You can see here that, as usually you would have a T cell that expresses a CAR, but in this situation, they have a two-step procedure. It's only expressing the CAR if it gets antigen A, so there's a gating system here. So only if the cell encounters antigen A will it then have a downstream cascade of events to then transcribe the CAR, and that CAR would be specific for antigen B. So for example, in the setting of multiple myeloma, if you just had a few cells that start popping up, and they're CD138 positive, if you have a few CAR T cells lying around that are maybe the memory-like T cells, and they get tipped off by that first antigen, 138, then those T cells will then transcribe the CAR, which is against BCMA, and expand that CAR T cell population, very similar to how our own T cells work when we encounter something like a memory antigen. And so this idea is actually, in my mind, suited quite well to a disease like myeloma, which tends to be a waxing and waning disease, and we may eradicate it, but as soon as there's a few cells, it starts to get out of control in the relapse setting. And so this is some kind of technology that might be best suited to a disease, for example, like myeloma, or CLL, or follicular lymphoma. What about T-cell engineering to make the T-cells more like our T-cells? So Justin Eckheim is a very talented senior scientist, postdoctoral scientist at UCSF in the Parker Institute, but was formerly in Michelle Satterland's lab in Memorial Sloan Kettering. And what he developed is this track locus engineering. So usually when we give T-cells with CAR T-cells, we have a vector that's then a viral vector, and the T-cells are transduced with the virus, as we heard this morning. But in this situation, he uses CRISPR technology to insert that CAR T gene directly in the TCR receptor alpha locus. So now, instead of expressing the TCR, this cell is going to express the CAR where it would usually express the TCR. So why is this important? If you think about it, now the T cell is under its own physiologic control, and what ends up happening is that it's able to be less exhausted and more effective. And when he compared it to a standard this is now a CD19 model, but when he compared it to standard CD19 retroviral CAR T cells, like the Kite product, for example, he was able to show that his tracked T cells actually were able to be more effective at eradicating CD19 disease. And if you look at the phenotype of these cells, what's really interesting, if you look at the phenotype, you can actually see here that one of the reasons why there may be more efficacy of this track locus T cell is because they're behaving more physiologically and they're less exhausted. So if you look at the exhaustion markers, particularly TIM3 and LAG3, you can see here with the track locus CAR T cells that they actually express these less. And that means that they're less exhausted. And you can see that on the pie chart on the right-hand side, that these T cells are actually less exhausted, and it might explain why they could actually be under physiologic control, and that's actually more natural for the immune system to actually have waxing and waning T cells so that they can not be exhausted and actually control disease more physiologically. So that's something we're interested in. What about timing? We've been talking a lot about T cells and composition, but the reality is we're apheresing all these patients where they've had multiple lines of therapy, and maybe those T cells aren't that healthy. And we know for myeloma that actually the more lines of therapy you have, the shorter your duration of responses, and the less likely you're able to have the response. So wouldn't it be better if we took this awesome response we're having with CAR T cells and bring it more proximal? And in fact, maybe CAR T cells should follow the path of daratumumab. And as all of you know, daratumumab used to be something we used in such late line, and now slowly but surely over the past 5 years, we've brought it more proximal, and we're getting very nice early strong responses, bringing daratumumab into the frontline setting. So my friend Al Garfall looked at this. He's also at the University of Pennsylvania, and he was able to show that if you take T cells from a patient who's been heavily pretreated and you apherese that patient, the T cells that you get are much less healthy, suggesting something that we probably already knew, right? The more treatment you get, the more steroids, all of these things that we do to myeloma patients, the less healthy your T cells are going to be. And because of that, we're thinking about other trial designs. So this is the BMT-CTN 1901 trial that we're trying to get off the ground. And here we're going to take patients who are an unmet need. In my mind, those are upfront high-risk patients. We do horribly with those patients. Shaji already talked about the high-risk features. In this case, we're going to use revised ISS-3, so those patients with adverse FISH findings and high beta-2 microglobulin. We're going to take those patients, they'll get induction, dealer's choice. But before they get their stem cells harvested, they're going to first get T cells harvested. Those T cells are going to be sent off to be made. The patients will get their transplant. And instead of doing a tandem transplant, we're going to consolidate them with a CAR T cell to try to eradicate any of that long-lived MRD that they may have there. And then we're going to take them to Len maintenance. So this is a trial that we're really excited to get off the ground. We've had some back and forth with the FDA about this design, but I'm hoping that we'll be able to get it off the ground. There's a similar trial that's being run by Celgene in parallel with a similar patient population. Similarly, the protocol 1902 is a sister protocol, and in this situation, we're going to take patients who go through myeloma induction and transplant, but even after 6 months of maintenance aren't in a VGPR or CR, those people are bad actors, right? They're not doing as well as they should on lead maintenance. We know they have a lesser duration of response, and we're going to take those people and give them CAR T cells and then lead maintenance. So this will be an unconventional way to treat some people, but really looking at those people that are high risk, either by initial prognosis and FISH, or by how they're behaving clinically, and bringing these therapies more proximal earlier in their treatment to get healthier T cells. There are other clinical trials looking at this, not just from cooperative groups, but from industry, and I actually really applaud industry for thinking about this sooner than later. And then there's another thing that might help timing, which is allogeneic T cells. If you think about it, we take 4 weeks, 5 weeks to harvest the T cells, send them off to wherever, get them made, and bring them back. A lot of that time is spent doing the QC, making sure there's no mycoplasma, all these things that we have to worry about. If we could just X out that entire part of it, that we would be able to get off-the-shelf T cells, which we've talked a lot about, allogeneic CAR T cells. What would this do? This would improve timing. You could plan much easier for your patient, but it would also improve the T cell health. And so one of the companies looking to do this is a company called Allogene. They use an talent technology to get rid of their TCR, so there's no graft versus host. And then they have an interesting lymphodepleting system with a Campact-like drug to get rid of all the inherent T cells. And then they're going to give allogeneic T cells either in lymphoid populations against CD19 or for our patients with myeloma against BCMA. And this trial has actually recently launched and is just in the early phases right now. So just one last thing, maybe we don't have to be thinking outside the box, but rather thinking inside the box, because CAR T cells are a new place for innovation, as we've talked about today. Remember, this is a living drug, a living thing that is really important to manipulate and think about how you can do. And sometimes the science is going faster than the actual implementation. The manipulations are more varied, there's more room for us to be creative, and the patients are their own laboratories. And so it's important to remember that we have not only what we can put into the cell, but what we can also give to the patients, for example, other immunomodulatory agents. And I think getting from academia to industry has actually caused a little bit of an identity crisis for us, and we see this in our own institutions. Are we cellular therapists, or are we just using drugs that are cell therapies that other people are developing? We don't want to stop using our academic brains and our academic development just because something has been taken over by a drug company. We don't want to stop our own development. And so because of that, a lot of us have been getting a lot of excitement over this Miltenyi Prodigy system, which Shah also said that you guys are getting this here as well. This is a sort of a easy bake oven. Actually, I have a picture of myself. There we go. Yes, it's actually like this very nice tabletop cell therapy system. And what you can do is actually put in your cells on the left-hand side, and they zip out. So you put your cells in, and the cells are separated. Get your PBMCs, and then you spit in your vector, and then we shouldn't spit it in, we should pipette it in. And it's a closed system, so you already have it in chambers, and it does it for you, and it cultures the cells, and over time it exchanges media for you, and kind of goes to the right-hand side. 14 days later, you might have an entire cell product, and you've made that just for yourself. So in America, whenever you get things delivered, all we call it Grubhub or DoorDash, but this is sort of like making your own cake, or getting your own Betty Crocker cake. So this is what this is, and a lot of people say, well, okay, you're going to do this, so you're not going to really be able to replace big pharma, right? You're not going to be Celgene, you're not going to be Novartis. That's true. we're not going to be able to make 1 million drug products, 1 million cell products in each institution, but what this will give us is academic freedom. And I think this is important because if we want to keep generating new ideas for cell therapy and getting past that plateau or getting to the plateau, we have to think, okay, maybe if we could put all these ideas together. For example, let's say you wanted to have an idea that would increase persistence, and you wanted to have an idea that could increase ability, and you wanted to have an idea that could actually physiologically make these T cells more active and less exhausted. You as an academic researcher can do this with this sort of cell system. So I want to conclude in saying that CAR T therapies are poised to become part of our treatment paradigm, our treatment algorithm, not only in myeloma, but other hematologic malignancies. But maybe we shouldn't wait until the last minute to use it when all the cells are less healthy than they would be at the beginning of our therapy. Maybe today's CAR T is the same thing as a Palm Pilot. I don't know if any of you guys ever had one of these, but I certainly wished I had one back in 2002. But maybe we need to make them more like the iPhone. We need to make them more successful. We can use immune profiling to do that, novel engineering and culturing techniques. And also we have to design better trials. Maybe we shouldn't be waiting for PFS to decide what's best. Maybe we should use MRD negativity as an endpoint. Because as I always say, I'm a myeloma millennial or myellennial, meaning I always want to get things as quick as possible, don't want to wait for things. And that's one of the ways we can make therapies and designs more efficient. With that, I want to say thanks. This is my team at University of California, San Francisco. This is our core in the center and our research colleague, Dr. Rita, and that on the right is us at our Cinco de Myeloma party. So if anybody wants to come visit us, we're always happy to have any visitors in San Francisco. Thank you very much.
Thanks, Dr. Shah. We don't have time for questions. And we'll go to the last speaker.
Do you want one question?
Okay. Go ahead, please.
So thank you for the extensive review. My question with the coming anti-BCMA antibody, you think it might replace CAR T cell with less toxicity? How would you incorporate both of them?
You mean bispecific therapy or antibody conjugate?
The anti-BCMA antibody, the GSK.
The GSK. Yeah, I think it's going to be a clinical setting because the GSK antibody conjugate is off the shelf. You can just order it, right? Whereas for CAR T, you have to make the cells. So I think patients who are able to get themselves to a specialized center are going to probably be able to get CAR T, but maybe some older patients or patients that don't have access will stay at their local oncologist and they can get the BCMA ADC. So it'll be different populations, I think.
Not a question, but I'm just going to make a comment. I'm sorry, just to say that the debate that was going to happen at 2:45 was going to be an allo-auto debate, but in the last minute it's been changed to an in-house CAR T versus commercial CAR T with Saad Kandarian and Dr. Jacobs.
Great. Good lead with. Go segue.
Thank you so much.
Thanks.
Very nice talk. Next.